asthma, COPD. What did you teach today?
Pharmacotherapy.
Pharmacotherapy. So let's just go into the pharmacotherapy of asthma. Okay, asthma is a disease where patient gets extremely hyperreactive airways. So one of the most important drugs that you want to use is what?
Beta.
Beta 2 agonist. Now, what is so difficult about this beta 2 agonist? What is so difficult? The difficulty with the beta 2 agonist is how to get it inside the body, how to get it inside. No, when I say beta 2 agonist, we are talking of Duolin, we are talking of salbutamol, we are talking of albuterol, we are talking of levosalbutamol. This is beta 2 agonist, right? The cornerstone of an asthmatic treatment is beta 2 agonist. The issue is how to get it in. उसको अंदर कैसे लाने का सबसे बड़ा इशू ये है. हमको ऐसा लगेगा कि हमने ठीक है, we have started a nebulizer and it is going to go inside. But I don't know how many of you all are aware. How much of the nebulizer is actually going inside the patient?
12%.
Hardly 12%. And 12% at best. 12% at best. That means at best means patient is calm, quiet, going inside. Our patients are trashing about. And the ICU patients are different from the ward patients. So on an average, it may not be more than 4 to 5% that is actually getting inside. It may not be more than 4 to 5%. Now when you say getting inside, how can you make a nebulizer effective? If I ask this question, so what are the few points that you will tell that will make the nebulizer effective? That our therapy, our pharmacotherapy therapy, if I say 4-5 points, what are the 4-5 points? That some relative is there, I want that this therapy should work. What will I do? Say, let me convert from mechanically ventilated to spontaneously breathing. Okay, so in spontaneously breathing patient. Yeah. So how can you make my therapy? How can you make my therapy perfect? But the 12% तो जाए अंदर. हमने बोला ना 12% is the minimum it is going inside. 12% तो let it go inside. Out of the 100%, at least 12% let it go inside. When I say inside means how do you make it perfect?
The nebulizer chamber which we are giving to them.
Spacer.
So there are certain things that you must understand when we talk about nebulization. One thing that is very important when you are nebulizing is the particle size, the aerosol that is formed. When you nebulize means you are talking of aerosols. They are aerosols, right? It is the aerosol size that actually determines where your particle is depositing. If your aerosol size is very high, say 10 microns, it will deposit in the nose, in the mouth. You don't want the effect. If your particle size is too small, less than 1 micron, it will go in and come out. It will not get deposited anywhere. Because for it to deposit, it needs some weight. It has to sediment. It has to sediment, it has to fall and stop somewhere. So if it is very light, less than 1 micron, क्या करेगा वो? It will go inside and come outside. It will not deposit anywhere. For it to deposit, I need to be somewhere around 3 to 4 microns, 3 to 5 microns. For the aerosol particle to deposit inside the airway, which I am talking of, is a respiratory bronchiole. That is where I want. वहाँ पर bronchoconstriction हो रहा है. ट्रैकिया में थोड़ी हो रहा है bronchoconstriction. मेरा bronchos किधर हो रहा है? इधर हो रहा है. For my aerosol to deposit, it has to deposit in the respiratory bronchiole. You're understanding? So that time the particle size has to be somewhere between 3 to 5 microns. Now why is there such a big range? Because the particle size is not one. जब ये aerosolization form होता है ना, so there are ranges of particle size. So we have to have the median of those ranges. That is called as mass, median, aerodynamic, diameter. What is it called? Mass, median, aerodynamic, diameter. मतलब it is the median of the mass that is of the particles that is going to go. So the mass, median, aerodynamic, diameter has to be between 3 and 5 microns. You understand? जब हम nebulizer यूज करते हैं ना, normal small volume, हम ये nebulizer जो यूज करते हैं इसको क्या बोलते हैं? Small volume nebulizer. What is it called as? It's called as small volume nebulizer. जो हम दूसरा एक छोटा सा वेंटिलेटर में लगाते हैं उसको क्या बोलते हैं? एरोजेन बोलते हैं उसे. एक डब्बा यूज करते हैं उसको क्या बोलते हैं? अल्ट्रासोनिक नेबुलाइजर. So when you say nebulizer, these are the three devices that we know. We know a small volume nebulizer, we know the aerogel, and we know the dabba that is there, ultrasonic nebulizer. Now, what are the main differences between all of these three? One of the main differences, the particle size is one of the main differences. The particle size. In the small volume nebulizer, the particle size can go anywhere up to 10 microns. It's not, all the particles are not, majority of the particles are not the actual particle size. How does a small volume nebulizer work? So how do you know which are the particle size? If you take that nebulizer in your hand and you open up the nebulizer, there is a sheet inside which actually tells you the particle size, mass between aerodynamic gravity. Okay, so we are hoping that most of the particles are the size of 3 to 5 microns. So how does this small volume nebulizer work? कैसे work होता है strictly? कैसे work होता है? How does it work? अगर आवाज आ रहा है, is it working well or is it working lesser or working more? If it is making noise, ऐसा आवाज आ रही है. Yeah, if the sound comes, that means the particle size is not okay. It's not working. Surprisingly, people make the sound. People try to make that sound rather. वो sound अगर आ रहा है, मतलब which is sputtering. If it is sputtering, the particle size is not adequate. It is too large. It's probably going to go in the eyes. It's going to go in the nose. It's not going to get into the airways. You understand? So what should be the approximate liters that you should give? Approximate liters when you are starting the nebulizer should be? It should be 6 to 8 liters. It should be how much?
6 to 8.
Why is that so? Because how is this working? This is working. How is this working? By Venturi's principle. Do you know what Venturi's principle? So what is Venturi effect and Venturi principle? How does it work? So you have, let's take the nebulizer to be a container like this. Okay? उसके अंदर एक green color का छोटा सा होता है, हाँ? उसकी टिप पे छोटा सा होल होता है. You have seen that, right? ऐसा एक nebulizer होता है. नीचे एक कंटेनर, ऊपर कंटेनर होता है, उसको हम जॉइन करते हैं. हाँ? उसको जो ऊपर का कंटेनर में there is a green small spout. हाँ? On top of it there is a small hole. अभी हम 6 लीटर दे रहे हैं. आवाज कितना दे रहे हैं? 6 लीटर. ये जो होल, ये जो ऐसा स्पाउट है उसके आजू बाजू 2.5 to 3 ml हमने भर के रखा है. उसका fill volume बोलते हैं उसे. Every nebulizer has a fill volume. Read up on that sheet what is the fill volume. On an average it is 2.5 to 4 ml. That is the fill volume. You cannot fill 8 ml. You cannot fill 1 ml. That fill volume has to be filled accordingly. Clear? Otherwise the particle size will change. The fill volume, if it is 4 ml, it has to be 4 ml. If the fill volume is 8 ml, it has to be 8 ml. 8 ml नहीं होता है, 2.5 to 4 होता है. Clear? It has to be that fill volume. How does it work now? That fill volume you put it around this, and this is where the tube is lying. Now 8 liters are coming in full speed from here, and when it comes here, suddenly it becomes very small. ये तो बड़ा ट्यूब है, बड़ा सा ट्यूब है जा रहा है यहाँ से. It's a very big tube that is going from here. The moment it reaches the top, suddenly there is low pressure. High pressure, high pressure, high pressure, high pressure, highest pressure, highest pressure, highest pressure, and suddenly there is low pressure here. Because वो suddenly open हो गया, पूरा हवा में हो गया ना ऊपर. समझ में आ रहा है? वापस समझाता हूँ. वहाँ से 6 liters आ रही है. 6 to 8 liters is coming from there. High pressure, high pressure, high pressure, high pressure. Even more high pressure because वो और छोटा हो गया ट्यूब वहाँ का. हाँ? और इधर आएगा तो even very low pressure हो जाएगा. वो suddenly open हो गया है. So very low pressure. When low pressure of this nature occurs, this fluid that is lying around it, it goes towards that. The fluid that is there around it, it is drawn up towards that. It hits the baffle there and it makes it to aerosols. So what does this mean? This means that if I want to aerosolize properly, I need my fluid to be staying like this, not like this. What does this mean? If I want my SVN to work, my SVN should be erect. It should be like this. It can't be like this. It can't be like this. Though it is making noise. Though it is making noise, it's not working. For it to actually go from there into the tube and then sputter from the baffle, it will need to be in that particular level. That's why that fill volume. So you can't turn it around. You can't turn it around. In the SVN, we can't have the sometimes patients lying down and attaching it. You can't have the SVN slightly turned or slightly. It has to be erect. Clear on this? Clear on this? the fill volume. So that is small volume nebulizer. Where do you place this? Now you have two kinds of patients. You have patients who are mechanically ventilated, and you have patients who are spontaneously breathing, or you have patients who are on NIVs. There are three kinds of patients. No, you have patients who are on mechanically ventilated patient. You have patients that are spontaneously breathing, and you have patients that are on NIV. And NIV are of two types. You have the NIV that is from the ICU, and you have NIV that comes from home, where there is an exhalation. हमारे पास तीन टाइप का पेशेंट होता है, तीन चार टाइप का मशीन होता है. One is the patient who is spontaneously breathing. The second who is on mechanically ventilated. The third is who is on NIV from the ICU, and the fourth is the one who is on NIV from a spontaneous home ventilator, from a home NIV. What is the difference between home NIV and ICU NIV? The home NIV has got an exhalation valve or a port somewhere, which the ICU NIV does not have. Right? So where do you place this? So usually this, if you want to, let's take the category of spontaneously breathing patient. Spontaneously breathing patient is हम लोग के पास आएगा ही. वैसे नॉर्मली पेशेंट है, वो ऑक्सीजन नहीं है, कुछ नहीं है, वो पंप ले रहा है, वो हमारे पास आएगा ही वार्ड में. So let's only consider it. Right? Let's go to mechanically ventilated patient. In a mechanically ventilated patient, where do you keep the nebulizer? Where do you keep it? So I'll give you an idea. You have a tube, okay? You have the Y piece coming here. You have the entire limb that is going into the ventilator. So you have three or four positions to keep it. One is between the tube and the Y piece. There is between the Y piece and the inspiratory limb. Near the exhalation port. So there are three places where let's put as three places. One is before the Y piece, before the Y, that is between the endotracheal tube and the Y. Just after the Y, just after the Y, before the bifurcation, inspiratory limb, and near the exhalation valve. Exhalation valve is there, no? Expiratory limb. So where are you going to place it and why? If I ask you this question, where? Sorry? So the ideal position. Anyone who wants to put it in the inspiratory limb? Hands up. You want to put it in inspiratory? How many hands up? Anyone who wants to place it between the endotracheal tube and the Y piece? Endotracheal tube and Y piece के उधर. Anyone who wants to place it near the expiratory limb? The rest don't want to nebulize or what? Because there are only these options.
Inspiratory.
So the answer is actually, the right answer is to place it 13 centimeters away from the Y piece on the inspiratory limb. That is the actual answer. The actual answer is 13 centimeters away from the Y piece on the inspiratory limb. This is when you're using small volume nebulizer. This is when you're using small volume nebulizer or using meter dose inhalers. जब आप MDI यूज करते हैं, MDI right? वो ऐसे करके करते हैं, पंप करते हैं नम वाला. So that MDI if you're using, you need to place the canister, you need to place the device from which you're going to puff it 13 centimeters away from the Y piece on the inspiratory limb, and it has to be actuated at the height of the inspiration. Okay, so this is very difficult to do. इसलिए MDI हम यूज नहीं करते, क्योंकि हमको देखना पड़ता है कभी इंस्पिरेशन अच्छा ऐसा करके मैं तो कर ही नहीं पाऊंगा मैं. It's not possible. It's difficult, very difficult. That is why we have built-in nebulizers in our ventilators. What does these built-in nebulizers do? They actually give the nebulizer during the inspiratory phase, and they switch off the nebulizer during the expiratory phase. And that is the reason that when you are actually using nebulizer, don't use it with the flow meter only. Press the nebulizer button on the ventilator. Press the nebulizer button on the ventilator, because what that happens is it gives the nebulizer at the peak of inspiration, and then it gets off. Then again it gives. समझ में आ रहा है? So that is the exact question. Now when it comes to NIV, the problem is what? What happens with an NIV? So you have certain NIVs with a home bypass where the exhalation valve is here and your mask is here. Exhalation valve is right here. There's a small hole there. There's one where the hole is right here. right? And there is one with the mask में hole रहता है. So where will I want to put this? Where? So I will want to put it before the leak. If the leak is here, I want to put it in the center here. You understand? The nebulizer has to be here, not after the leak. I'm not going to put it there because I have an attachment there. समझ में आ रहा है? हाँ, it has to be before the leak. हाँ, अगर मेरा leak उधर है तो मैं इधर लगाऊँ. Right? If my leak is here, I will not put it here because it's easy to put it here. इधर लगाना easy पड़ता है, but you have to put it here, between the mask and the leak. Clear? Understood? Huh? On an average, don't try to do all these things. Just remove the mask and put a normal nebulizer. It makes it much more easier. You know, it's very less often you'll have to do something like this. ठीक है? Clear on smaller nebulizer? Now, what are the practices in a smaller nebulizer? If you want to give SEN, what do you go to do? Number one, I will try to place the patient in an erect position. If I don't place the patient in an erect position, it is very difficult to actually place the SEN in an erect position. Okay, so the patient has to be in erect position, sitting up, when you're doing smaller nebulizer. Clear on this? Second thing, I have to do a suctioning before doing this. How much is the deposition you said, Ruchika? 12%. उसमें भी अगर एंडोट्रेकियल ट्यूब में अगर कुछ ब्लॉक रहा, कितना कम हो जाएगा? You understand? Huh? So I can't afford to have even the slightest of the mucus in the endotracheal tube. Even if the slightest of the mucus is there, my nebulizer will not work. It happens very often. You know, you are having a patient on the tube and patient having bronchospasm. It's just not improving. One of the reasons that you can look at is whether the tube is kind of having mucus around it, because what will happen, this will impact the mucus. It will not allow it to go inside. So suctioning is very important. The third is placement. Where to place it, we discussed. Okay, we discussed where to place it. If you don't have 13 centimeters away from the Y-piece, place it at least after the Y-piece. Okay, place it after the Y-piece. Clear? Clear on this? Fourth thing, reduce the respiratory rate as much as possible. Increase the tidal volumes and try to have an inspiratory pause. Clear on this? Inspiratory pause, increase tidal volume, reduce the RR. These are the three things that you probably want to do when you are nebulizing your patients. But we end up not doing all these things because what we do is we attach it to the nebulizer circuit and we press it on. This is what happens. Clear? Importantly, once nebulizer, this how much time does a SEN take to empty? Chandrima, how much time does a small nebulizer take to complete its entire course? It's 15 minutes. It doesn't take lesser or more. It takes exactly 15 minutes. Okay, around 15 minutes you will get over. So what is important for you? At the 10th or 11th minute, you are supposed to tap the nebulizer for all the drug to fall in back. Understand this. This is aerosolizing. So it is going to be on all the side surfaces of the nebulizer. So it's important to tap the nebulizer and ensure that the rest of the drug is getting nebulized. What you must understand is, in that 12% that you're talking about, there is almost 1 to 1.5 ml that is wastage. Yeah. So there's a huge amount of drug that is also getting wasted in this small one nebulizer, because 1 to 1.5 ml is actually wasted. You can't nebulize it. It cannot work. It doesn't work. It doesn't allow it to completely become dry. नहीं होता है. Are you understanding? It will not become dry. So 1 to 1.5 ml drug is getting wasted. So you can imagine how difficult it is to nebulize your patient. Right? And that is why we have higher generation ventilators called as vibrating mesh nebulizers. That is why on an average, if you want nebulization to work, I would rather use the best of the therapy, and the best of the therapy that we have presently in the evidence in the market is vibrating mesh nebulizers. जो हम aerojet बोलते हैं, they are vibrating mesh nebulizers. Clear on this? हाँ? Vibrating mesh nebulizer समझ में आ गया? Mesh nebulizer. What is vibrating mesh nebulizer? क्या होता है? Any idea what this is? Any idea what this is? This device, this is so small over there. We see that aerojet is such a small device, but it is a very, very powerful and a very, very sophisticated device. what happens in this device? It's an extremely sophisticated device. So उसमें क्या हो रहा है? There are thousands of funnel-shaped holes inside. Inside the device, there are thousands of funnel-shaped holes on a disc, on a plate. Thousands. Okay, and when you switch it on, there is a current or there is an ultrasonic or a piezoelectric crystal that actually makes it vibrate at speeds that are extremely high. Clear? It vibrates full speed when it vibrates, and as it's vibrating in that huge speed, these funnels actually create aerosols of the exact diameter that we want. Okay, 4 to 6 microns. It actually creates that 4 microns size aerosols. You understand? And these aerosols are the ones that get into the trap. Now, importantly, what? This does not need a specific nebulizer to be attached, because these are breath actuated. You don't need to attach it and press nebulizer there. You don't need to attach and press nebulizer because they are breath actuated. But what happens over here? When the patient takes breath inside, the nebulizer gets on its own. They are breath actuated. So they are breath actuated. They don't require all that sophistication where you put the nebulizer and then you press a button. You don't need to do that here or there. You just attach it, it will start working on its own. They cannot do that. It just attach it, it starts on its own. You don't need to press nebulizer here. Second thing, you don't need to be in that erect position. You can keep it ulta also. You can keep it ulta also. Erect position की जरूरत ही नहीं है. तो तुम उसको उल्टा भी रख सकते हो. कुछ फर्क नहीं पड़ने वाला. It will still nebulize the right way. उसको उल्टा भी रख सकते हो. Third thing, उसका wastage is less than 0.5 ml. Drug wastage there is less than 0.5 ml. हम लोग अभी drug wastage 1.5 ml था. It is less than 0.5 ml with aerogen and crisis. Are you understanding? And third, and it doesn't depend where you want to keep it. You can keep it anywhere in the circuit. It will still nebulize very, very well. You understand? Aerogen. That is why we preferably use the aerogen nebulizer in the ICU. Clear on this? हाँ? वो दूसरा जो डब्बा आता है, बड़ा वाला डब्बा, हाँ, अल्ट्रासोनिक स्कोप बोलते हैं, नेबुलाइजर. The problem with that is it creates noise. The second thing that it creates is it warms up the solution. So if it warms up the solution, certain solutions may not work. You understand? Certain solutions it may denature, it may not work properly. So like antibiotics, it not work. So ultrasound, we don't want to use that. But when to use that? If you don't want to use oxygen, you use that. But aerogen plays all the roles everywhere. Aerogen we can use everywhere. So in asthma, the first drug I want to give is what? Ruchika. Now you know that if I'm going to use the beta-2 agonist, I'm going to use it along with the aerogen. This is very clear now. This is very clear because my first treatment is nebulization, and it has to be the bronchodilator that is going to work 100%. And according to me, aerogen nebulizer is the one that gives me at least 30% of drug deposition. What was the estimate giving? 11 to 12%. What is the aerogen giving? 30%. वो भी 100% नहीं है, 30%. लेकिन at least it is 3 times that of the small nebulizer. So I'm going to use my aerogen in these cases, right? Now, which is the drug I will use? Beta-2 agonist. And how will I use it? I have a patient in front of you. You have to give an order. What will you do?
We usually use salbutamol.
No. So you have to give an order. You have to write on your sheet. What are you going to write on your sheet? You have to give an order, right? You usually give, that's fine. What do you write?
2.5 mg every 4 hourly.
What are we using usually?
Respules.
What you are talking is what? You are talking about albuterol.
We are using.
See, when you go in the exam and when we ask such questions, this is what you answer. What does it indicate to me? What does it indicate? That you have never worked on. Which is right. Because you have not seen what is there in that. Do you give 2.5 anywhere? Do we use albuterol? From where you are just pumped up just before the exam to give in the exam. It sounds like that. You are understanding how it sounds? You are understanding? What are we using?
Respules.
Leosalbutamol.
Leosalbutamol.
You have to tell what you are using because we know what you know. You understand? So the questions are very simple, but if you make the answers complex, you lose your exams. Chalak, you agree to this, right? The questions are simple, right? But if you can make it complex. It's like that. It's very basic. It's very basic. And if I ask you a question like this, and if you say 2.5 albuterol, I think you're in US. Albuterol is US. You understand? Huh? What do you use in India?
Levosalbutamol.
1.2. Huh? So how often do I use this? Next question. Because I have to tell you now. This patient is an acute exacerbation of asthma, and I have to give nebulizer. Now, what are you going to instruct the nurse? What are they going to do? What are you going to give them? Nebulization de do. How much hours? What? Why? What are you going to watch? Because every drug you give will have a reaction, will have a side effect. You have to watch for something. You have to give it at a frequency. What is the frequency? What is the side effect going to look at?
Every 6th hour.
So that patient will die by that time.
Every 20
If
minutes.
he's going to have so much of asthma that is coming to your ICU, if this patient is coming to the ICU, so much of asthma, okay, that he requires ICU care, if you're going to give it 6 hours, it's just one dose you're going to give?
Every 20 minutes.
Sorry? Yes. So you're going to give every 20 minutes. Every 20 minutes, every 15 to 20 minutes, I want to give levosalbutamol nebulizer. Every 15 to 20 minutes, I want to give levosalbutamol as a nebulizer. I can even give it as an infusion for the first 1 hour. Continuous. Okay, it's going to be because this patient has acute exacerbation. In the meanwhile, I want to look for the side effects, which includes first myoclonus, asterixis, then comes tachycardia. Okay, myoclonus. मतलब myoclonus तो ऐसा कैसा झपकी मूवमेंट्स आ रहा है, एक ऐसा जंप हो रहा है, asterixis आ रहा है, हिल रहा है हाथ उसका. हाँ, आपने कभी लिया है नेबुलाइजर? मैंने लिया है. तो I know your hand ऐसे हिलता है. When you take nebulizer 3-4 times now, your hand it starts shaking like this. You can't hold the pen properly. So there are side effects. So you cannot just keep giving that. You have to be certain. So you're going to write over there, nebulizer with an aeroneb nebulizer every 15 to 20 minutes till the patient improves. Till the patient improves. And what is the characteristic of improvement?
Reduce reduce.
What? Clinically what? Because you have to tell the nurse, no, to stop nebulizer. It will be based on something. You can't just nebulize and say, keep nebulizing. It has to be stopped on basis of something. What is it? Alertness. This is asthma. Asthma, alertness, COPD is different, asthma is different. Understand all these things, because when you are going to be working alone, you need to give certain XYZ terminology to everybody. COPD, we talk about alertness, because the classical COPD patient will come to you with CO2 narcosis. Asthmatic patient, once he becomes unalert, he has to be intubated. He will be intubated if he is going. So what are you going to look at? So you have to tell me these things. Yes, it is your respiratory rate. No, it is your respiratory rate that has to settle down to adequate levels. It has to be your tachycardia that is settling down a little bit. It has to be the distress that you see in his physical status, which is accessory muscles of respiration gets better. It is going to be your blood pressure that is going to settle down from what it was. Because this patient is going to be an intense sympathetic drive. उसका blood pressure ज़्यादा रहेगा, उसका pulse rate ज़्यादा रहेगा. He will be sweating and die for headache. He will have ananesia flaring. He will have the RR to be more than 45-50. You are understanding? So you want to see these things whether this is settling down, because you don't need after that. After that, you need maintenance. Right? So the first thing I am going to concentrate on is giving the nebulizer. Clear? Now, when you are very severe condition, when your condition is very severe, there is a high possibility that this patient cannot move this air in. जा ही नहीं रहा है अंदर हवा, because he is developing autopic. Here only, it's not going in only. Everything is here only. It doesn't go in only. It's not going in because of the amount of bronchospasm that he has. अंदर कुछ जा ही नहीं रहा है. Alright. So I will want to give some other form of the therapy. So I'm first talking about beta 2 agonists. And the other thing that comes is IV. If this is not going to work, I will use IV. So if I have IV salbutamol, it's a good idea to use that. But we don't have IV salbutamol. Okay, now we don't have IV salbutamol. So what do we use? So yeah, so you may want to use something different. But before aminophyllin doesn't have that kind of evidence in literature to use. You'll come to aminophyllin. So you can use adrenaline. Beta 2, the strongest beta 2 agonist that you have is adrenaline. So how much adrenaline will you give? IM. Simple. Give 0.3 IM. If 0.3 IM is not working, if that is not there, give IV. Take small dose of you start at 0.3 microgram per kilogram per minute, you start adrenaline. It will probably work. Bronchodilator, the strongest bronchodilator that you know of is adrenaline. Beta 2 EM. You understand? It is alpha 2, alpha 1, alpha 2, beta 1, beta 2. Beta 2 effect is very strong there. Adrenaline. IV. 0.3 microgram per kilogram per minute. Because if what is going to happen is asthma is a vicious circle. Asthma is a vicious circle. What will happen? If the patient gets bronchospastic, he will get tachypneic. If he gets tachypneic, he will get anxious. Once he gets anxious, he will breathe more faster. The more faster he breathes, more the auto peak. More the auto peak, again the whole cycle keeps on repeating. The entire point is, I need to reduce his tachypnea. I need to reduce his tachypnea. The starting bronchospasm tachypnea. If I reduce his tachypnea, the whole cycle will stop from coming down. So that's why my first metric that I'm going to see is tachypnea. My first metric I'm going to see is, अरे क्या है tachypnea कितना हो गया? 50 का 45 हो गया, अरे it's better. 45 का 40 हो गया, better. The RR that you're seeing on here, it becomes the best metric you can think of. That is why whatever drug I want to give, I want to titrate it to that very important metric that I have. That is tachypnea. Clear? You getting the point? So if I'm going to give a bronchodilator, I'm going to give it so often that I get down the tachypnea, that I get down the distress that the patient is having. So I went to adrenaline. So of course you also have the use of steroids, but we know steroids are going to be immediate working. It's not going to be working. I said I give steroid and patient become fine. The funny part about most of our ICU is पहला steroid अंदर जाएगा. Yes, it has to go in, but it's not going to be the one that's going to change it now. So if I have to give the steroid, what is the dose of steroid I will use? Dose? Yes, 125 milligrams of IV methylprednisolone. This is the dose I will use. I will use 125 milligrams of IV methylprednisolone. So as a bedside healthcare worker, we should understand these things because these are emergencies. I can't wait for a doctor to tell me इतना लाओ, ये है ही, इसका कोई दूसरा है नहीं, ये यूज ही करना है आपको, ये मंगाना ही है आपको क्या दूँ मैं, जरूरत ही नहीं है, मंगाओ ये, लगेगा ही उनको, ठीक है? 125 milligrams methylprednisolone has to go inside, right? It has to go inside. Better early than late. So better early than late. Okay. So now another very important drug, even before I talk about aminophyllin, what is another very important drug that basically you can use?
Magnesium sulfate.
Okay, but before that, so what you can try under monitored conditions in the ICU is to give a dose of an opioid. Okay, because what is my first thing I want to get? I want to increase my exhalation phase. If I increase my exhalation phase, my patient's tachypnea will come down. You understand it? अगर मैं exhalation phase बढ़ाया, expiration phase मैंने बढ़ाया, then there is a high possibility his air will escape out. He's suffering because of the auto peak. Air is not escaping out. If air escapes out, he will start getting better. For air to escape out, I have to reduce his RR. If I reduce my RR, my expiratory time will increase in any which ways. If I want to increase my expiratory time, I have to reduce my RR. And to reduce my RR, fentanyl as an opioid works brilliantly. But this has to be done under monitored conditions. You can't have the patient zonked off with fentanyl. You give fentanyl, the RR comes down because the patient starts feeling a little bit better. Your nebulizer is working. It can't be done. ऐसी में standard dose देके छोड़ दूँगा. No. I'll give 25 and see what happens. I'll stand there because it is that 1 hour that makes the entire difference for this particular patient. It is that half an hour to 1 hour that makes a big difference. So I'll give the small dose of Fentanyl and see if my RM come again. My nebulizer will go back. Okay? So when it comes to all these things and things are not improving, then you think of an aminophylline because it's a drug that is not very greatly evidence based. Okay? Now how do you give aminophylline Ruchika again? You have to write the orders, right? Of course, if beta 2 agonists I have given, I will also give an anticholinergic. I will also give glycopyrrolate or glycopyrrolate in these cases. It may also work. So I will give a combination of beta 2 agonist and glycopyrrolate, so it will be 20 minutes going on for 1 hour. Right? So that is 25 micrograms. That is 25 milligrams that we give glycopyrrolate. Okay, 25. Right? So now,
aminophylline we give it as an infusion, so 0.5 mg per kg per hour.
anyone else? Anyone else on this? No loading? So it's important that you know what you're doing, okay? So if you don't know now, every time if you depend on Dr. Vaijanti and Dr. Sonal to do your orders, it may not be a right idea. You are many times on your own. Many times, in fact, more majority than you're on your own. So you should be able to do these things. So what do you give?
Loading dose of.
So it has to be 5 milligram per kilogram loading dose of aminophylline. 5 milligram per kilogram of loading dose of aminophylline to go over 20 minutes. You have to write that very clearly. Because you want the thing to work fast, you can't give it has to be given at the rate of 25 milligram per minute. You can give it as fast as that. You can give it as fast as 25 milligram per minute. That means 4 minutes per 100, 8 minutes per 200, right? And 14 minutes per the whole 250 ml is gone, 250 milligrams is gone. 5, you will get to 50 milligrams. You're understanding, that's why 20 minutes. You understand? 5 milligram per kilogram per minute is what I'm going to give. Then, after you give this, then you require to give an infusion. What is the infusion dose? The infusion dose for a smoker is on the higher side. So if it's a smoker, it's 0.8 milligram per kilogram per minute. And if it is a non-smoker, it is 0.3 to 0.5 milligram per kilogram. Okay? Clear on this? So that is the dose you have to remember to give. Aminophylline. It's a drug that causes a lot of side effects. But be very careful using the drug because it can cause tachycardia, it can cause cardiac problems, it can cause a whole lot of issues that will come in with arrhythmia and all of the aminophylline. So it's not a great drug to use. But you may want to choose to use it if things are not doing bad. Clear? So I am not going to push my steroid. I just require 125 milligrams of methylprednisolone. If the patient improves, very well and fine. If it doesn't improve, next day I'll give another 125 milligrams. So it's 43 times a day or 63 times a day. You understand? So it's 43 times a day or 63. I don't require to give 500 milligrams. It doesn't make sense. It doesn't work like that. It doesn't work like that. It works as 125 milligrams. And if it doesn't, if it works very well and fine. If 125 is not working, 500 is not going to work. You more often than not, it is a beta 2 stimulant that is going to work. Beta 2 agonist. And then once this gets over, then next day onwards you can either start 60 milligrams of prednisone if it takes it orally, because it's equal to 125, or I will give 43 times a day of methylprednisolone or 63 times a day of methylprednisolone for steroid, if you really require the steroids. Okay? So among the drugs that you are giving, you understood now? Bronchodilator. So unless you write these orders to yourself properly, you need to, for your exam, read it. There's no option. If you are going to write this every day, you will not need to study for your exam. It's a way of life. It's a way of doing stuff. Like for example, if I'm going to walk out of the room, I don't think that I have how to walk. I just go to my upper my right leg should go, my left leg should go. I should be socially wala. It just happens, right? It should happen. If it happens, then you get better as time goes. You understand? Then only as a doctor, it's an emergency, no? At that point, रुक जा मैं medscape देखता हूँ. ऐसे थोड़ी चल सकता है. No, it doesn't work that way, right? So it has to be as it has to go with the flow. Then only it's going to work. Okay? So I think that's about it. Pharmacotherapy. So there are other medicines also that you can use. There is Helios, which you don't use. It's not known to be superior. What's heliox? What is heliox?
7.
Yeah, helium and oxygen combination, which will convert the turbulent flow to a laminar flow and across, and your beta 2 will go inside much more easier. Heliox. Magnesium sulfate can be used. It can be used to cause amount of bronchodilation. Will be careful while using magnesium sulfate. So there also you give around 2 to 4 grams. That can be given over 20 to 30 minutes. Okay, so it's all a 20 minutes. Remember, it's a 20-minute window always in this. In asthma, everything you say is 20 minutes. So magnesium 20 minutes, aminophylline 20 minutes, beta 2 agonist 20 minutes, everything is 20 minutes. Okay, so even your observation comes after 20 minutes. After my bronchodilator therapy, I must come to see whether how my patient is 20 minutes. It's all 20 minutes. Okay, so your note should be every 20 minutes. Coming to the condition of ABG here. Now, how do I understand SpO2 here? The important here is not ABG, the important is SpO2. What is the importance here? SpO2. If I'm going to look at my findings, I'm going to look at SpO2. Why is that so? I'm worried about what? PCO2 going up. What am I worried about? PCO2 going up, patient arresting. COPD and asthma, both में ये problem है. The COPD patient will have higher PCO2s and asthma patients are lower. So the first ABG that you get is very important. If you will take one ABG to have certain ki kya hoga. In my first ABG, what am I expecting to see in asthmatic patient?
Respiratory alkalosis.
What am I expecting to see? What will be the PCO2?
On the lower side.
PCO2 will be low. PCO2 will be 25, 24 because patient is tachypneic.
Yes.
You know, we're going to see that. That is going to be my first ABG. Okay, that is going to be first ABG. It is going to be low PCO2. When my PCO2 starts reaching normal, it is very scary. And when my PCO2 becomes above normal, what is going to happen? My oxygenation will come down. What are you going to see in your ABG? I'll repeat this once more. In your ABG, first, your oxygen will be normal. Your oxygen will be normal, 80, 90, 80, 90, 85, 90, ऐसा मिलेगा. In your ABG. So remember to do your ABG on room air. Very important. Do your ABG in room air. Why to do the ABG on room air? Because now you have the baseline SpO2 and that baseline SpO2 is your PaO2 also. You have your baseline now. Right? What you must know is at a given room air, the PCO2 plus PO2 remains constant. So if the PCO2 goes up, PO2 will go down. If the PO2 goes up, PCO2 will go down. But the combination plus of this will be the same throughout life. You understand in asthma? Clear? तो इसके बेस में तुमने अगर उसको ऑक्सीजन दे दिया तो फिर ये जो बैलेंस है ना ये हमको समझ में नहीं आया. That's why I don't give the oxygen. समझ में आ रहा है? Asthmatic patients classically don't require oxygen. नहीं लगता उनको ऑक्सीजन. They are not hypoxic. They are only hyperventilating because of bronchospasm. उनको ऑक्सीजन नहीं लगता है. समझ में आ रहा है? So don't give the oxygen. Why? Because because saturations are above 93. I don't need oxygen here. I don't need. They are 96, 98 होते हैं oxygen saturation. I don't need the oxygen. If you give the oxygen, you lose that metric, that saturation metric you lose. Because if there is a situation where this patient can worsen also. If this patient is worsening, the first thing that will occur will be you can't keep doing ABGs every 20 minutes. You can't do that. You understand? You can't do every 20 minutes an ABG. I can't do that. See, because now what we have decided in the middle to give fentanyl. Now you give fentanyl, there is a possibility the PCO2 will go up. There's a possibility. And how do you know that my PCO2 is going up and the patient is worsening? My PO2 will come down. And where will that reflect on the saturation? If you give oxygen, that will not reflect it. Are you understanding? Because I am telling you a potentially dangerous therapy to give small amount of fentanyl. Potentially dangerous. You may just reduce the breathing because you reduce the central drive only. At that time, if the PCO2 is climbing up, your PO2 will come down, the saturation will come down there. That is the reason that every 20 minutes it's important to look at the saturation without the oxygen. So if your saturation is 98, 97, 98, 97, 98, your treatment has started, it has limited 97, 98, you're doing very well. But if it has got from 97, 90 to 90, boss, there is CO2 retention happening, that's why this is occurring. This patient will probably need an intubation. Are you understanding? Though it's normal, it's probably going to need an intubation. I rather do my bronchodilator much better. समझ में आ रहा है? हाँ, so that metric is very very important for you. So in a patient, so the first ABG is going to be very important to understand the baseline saturations. Okay. The second, after that, how the ABG is going to progress? PCO2 will slowly go to normal, but the oxygenation will remain the same. Saturation will remain the same. Then what will happen? If he is worsening, PCO2 will go slightly higher, and that is the time the oxygen will start going down. That time this patient will probably need an intubation. That's why CO2 narcosis is last in asthma. You understand? CO2 narcosis is last. Asthma, if you have patient completely down, he needs to be intubated. That is not the case with COPD patients. There the PCO2 can be 90 and patient can be normal and talking to you. But when an asthmatic patient becomes drowsy and extremely down, he is near to cardiac arrest. COPD patient is not near to cardiac arrest. The asthmatic patient, if the PCO2, when the patient becomes drowsy, he is near to. Understand the difference. COPD patient drowsy, no cardiac arrest है. Asthmatic patient drowsy, cardiac arrest is here. Why? Because what is the pathophysiology here? Autopeep. The pathophysiology here is an extreme amount of acute autopeep that has occurred, and that autopeep is going to drop your cardiac output, and that is going to cause cardiac arrest. Are you understanding? समझ में आ रहा है? Whereas in COPD, your carbon dioxide is going up, but autopeep is not creating as much. It is CO2 narcosis there in the real sense. It's not so much of autopeep. You do some hyperventilation and you become normal and come out. Here you can hyperventilate this patient for cardiac arrest, you need intubation. Are you understanding? So there is a big difference when a person with asthma becomes drowsy versus a COPD patient gets drowsy. This is close to cardiac arrest, this is not close to cardiac arrest. So clear? Any questions? I just told you clinically all about COPD and asthma. Yeah?
Sir, if we are not having that erogen neb in intubated patients, so how to proceed for nebulization?
So it's the same thing. That's why we have this 20-minute windows. You cannot do anything more than that. You will have to use a smaller nebulizer to its ultimate capacity. That is by using the exact fill volume that is mentioned, using the drug that is supposed to be given through that particular device, attaching it to 6 to 8 liters, actuating it from the ventilator 13 centimeters away from the eyepiece or at least away from the eyepiece in the inspiratory limit. This would be the only way, and before which you're suctioning your patient.
Yeah.
So this will be the only way that you can take the maximum advantage of the particular nebulizer. समझ में आ रहा है? हाँ? समझ में आ रहा है? But the ideal thing is to actually have the erogen.
Yeah.
Very few hospitals in Mumbai also has erogen.
Yeah.
Very few. Okay, we have it since many years now. ठीक है? हाँ? So even if you have to nebulize any patient, try to use the erogen otherwise also. Let it not be asthma. Otherwise also use the erogen. Now you have understood why to use the erogen. Okay, because it's much more superior, 30 times versus 10 times amount of particles deposition. Huh? So try to use the erogen as much as possible. We have that. Right? Especially when you're nebulizing antibiotics. Which are the antibiotics you can nebulize? Tobramycin, amikacin, cholesterol. These are all antibiotics that you can nebulize. So when you're nebulizing these, it is all the more reason that you use an aerogen. Because in that, if you use a smaller nebulizer, कितना wastage हो रहा है? You are understanding? Huh? It's important that reaches inside the patient. That is a fixed dose, finite dose. What is the dose? If you want to nebulize, the only drug that we are at the moment nebulizing are only 2, tobramycin and cholesterol. So you use higher doses, 2 million units of cholesterol 3 times in a day. 3 times in a day. We are using higher doses. Okay? We'll break forward. Okay?